in crime, Dr. Telly, before I move on to the next speaker, who is Mr. Saed Al Nobani from the United Arab Emirates. Thank you very much, Mr. Saed. I think you're muted. We're not getting any. Can you unmute yourself?
Hello?
Yep, we've got you there.
Good morning.
Thank you so much.
Guys.
Were you able to hear us?
Yeah, very good. So I'll just share my screen first. Okay. So can you see the screen?
We certainly can. No, not yet.
Can you see it now?
Yes, it's
okay.
there.
Okay, good morning, everyone. Nice to meet you all. I'm so happy to be part from this conference. My name is Saed Al Nobani. I am actually a clinical and patient education specialist, and I'm a senior Saudi Heart Association, American Heart Association life support instructor, and health quality consultant working in Cleveland Clinic, Abu Dhabi. Nice to meet you. Everybody can hear me very well? Okay, good. So actually, I will start about my presentation. It's actually, it's a study that done on 2017 in the Isr province in Saudi Arabia about something called essential safety requirement, which is part from the Sibahi accreditation in Saudi Arabia. So it's called Introduction for Quality and Patient Safety, Methodology and Arrangement for the Essential Safety Requirement in Healthcare Providers and Committee. That's mean how much, or what's the effect of the essential safety requirement on the committees that it's been done all over the Eastern Province Hospital. And there was around 45 a random sample from healthcare providers. We will speak about that in details now. Just before that, I need to start a little bit about introduction for the quality and what was the base. The agenda firstly will start with the concept of quality, patient safety and essential safety requirement, and result of study for the essential safety requirement with a multidisciplinary team in the random sample that I took. Now, beginning of the introduction, that what is the definition of equality? So literature review shows that the easiest definition for the quality is doing the right thing in the right way in the first time and doing it better in the next. That was actually the simplest definition I can get. To be based on that, to go through the study itself, we should understand firstly the quality and patient safety dimension, which is the abbreviation word is STEEP, which is the safety and timeliness, effectiveness, efficiency, and equitable and patient-centered. We'll go through them one by one in details, and we will base this dimensions on the study itself. So firstly, safety, you know, that all what we are doing as healthcare providers, that we want to maintain a high quality and patient safety for any patient who's coming to the hospital, especially a patient who's really admitted in the hospital for any reason, or a patient who want to do a surgery. I want him to have his surgery successfully and without any medical errors, without any problems. Effectiveness and efficiency, it's actually most of the people, they have confusion that effectiveness means doing the things in a correct way, but efficiency is doing the things in a correct way from start to stop. I mean, you have a straight line mentioning that I can start A and I will finish in Z. That's the shortest way. That's for me efficiency. And equitable, if you can see in the chart, if you can see the quality, I put a very nice example for you guys about 3 kids. They are trying to watch the game. So in the first part from the picture, you have the longer and the longest boy, then in the medium, and then the small. And all of them, they tried to watch the game, but they didn't get the chance. The shortest boy, they didn't get the chance to see the game. But in the equitable area, we found that the longest boy, he stand without any support. The medium was one support, and the shortest one had a 2 block support. And that's the meaning of the equitable, which we will focus that also in the presentation. Patient-centered care. Actually, this vision started around 1990s, in the early 1990s, 1992, 1993. They start to have a patient care-centered like acknowledgement. They start to understand that the patient-centered care should be started from the beginning of the patient who's admitted or he's coming to visit the outpatient department in the hospital. And that everything should be around the patient and his family. That's actually the dimension. And the most, the method that we used to do the BDCA for that is the focus BDCA. It's one of the very famous methods, which is the find, organize, and clarify, understand, select, plan, do, check, and act. Now, actually, I consider this man, he's in front of you, and the screen is like my career father. He's Dr. Edward Deming. He is the father of quality. Is very well known all over the world. Okay, this man, he has no relation with healthcare. He's not a doctor. He's not a nurse. He's not allied health. He is actually an engineer. And he started to have the quality thinking in the early 50s. And then he started to increase the quality aspect or the quality definition all over the world by doing many projects and many conferences to improve it. And what's actually one of the major speaks about him, that quality begins with the intent, which is fixed by the management. This is really, I saw it in the, in the real life. He has a big effect in my career. Now, imagine that I can give you an example. Imagine that you have a patient who's coming to see his cardiology doctor in the outpatient clinic. Then once he came, he found there is no spot available in the parking. When he came, there was no support for him at the beginning of the clinic, and the nurse was very busy to see him or to take his vital signs. Then he took maybe like 20-25 minutes to do the registration, then another 15 to 20 minutes to do the vital signs, and he waited around 2.5 hours to see his doctor. If you look to these arrows around you here, you can see that the arrow is going everywhere. So there is no engagement. There is no patient-centered care. There is no way to improve that. And in the same example, that if we had someone who is organizing the parking slot in the hospital parking area and help you to park your car so quickly, and when you come, you find the security officers or security members in the hospital door, they guide you to the information help desk, and then the information the help desk, you take you to the registration area, and you do the registration so quickly. Nurse coming to see you, smiling, having all that positive vibes, and she's like, as they said, that she's very happy and competent. Then you see your doctor. Your doctor has or he make the proper diagnosis for you, and then he prescribes some medication for you. You go into the pharmacy, you took that medication, and then you left. That maybe it's happening within around 2 hours, all this process. So this is aligning the arrow. Means this is the first example, and this is the second example. The first example with what was with the horrible way, and the perfect way of the aligning the arrow. So the quality is actually the same, these two examples. is you are trying to align the arrow of everything. Now, the model that we took for that there was around 25 to 42 healthcare providers. These healthcare providers, they are they want to prepare for the SIBAHI accreditation back in Saudi Arabia. And then this accreditation has something specific called essential safety requirement. So this essential safety requirement is like the international patient safety goal. It's the well-known international patient safety goal, which I will mention them next in the slides, that this is only 6 international patient safety goal, and now recently they tried to add another 3 or 4 to make it total 10. But the essential safety requirement for a hospital to be based in Saudi Arabia, enabled to be able to get the SIBAHI, it's around 20. So we took part from the healthcare providers, and we put them as a group, and we study them all over 1 year, 2 months. And then we teach them the essential safety requirement and how they handle it and how they want to improve it. And after the 1 year, 2 months, the SIBAHI team came from the SIBAHI surveyors, and they did the survey for the hospital, and the hospital they win the SIBAHI accreditation. So we want to see the training that happened for the last 1 year and 2 months, and arrangement for that all together, is how it's affecting the healthcare providers and how it affects the hospital itself. So the 7 quality tools actually that we used in this one, it was the flow chart, cause and effective diagram, check sheet, histogram, control chart, and scatter diagrams. And that was actually examples from what we took from the fishbone, the histogram, the flow chart, everything we use in every healthcare provider or every group, we use a different one. And we also put a SMART goal that we need to achieve the SIBAHI within 14 months. And that was actually a specific, manageable, attainable, and relevant and time-bounded plan, which is actually expanded around 14 months, which is long goal. Now, before we go back to the, I just want to focus on some kind of the indicators and how we handle that for this study. So the indicators is a quantitative measurement that based on numerous and treated over time for compassion to start benchmarking. And we use the benchmark that was in Saudi Arabia and actually in King Faisal Hospital, and specialist hospital in Riyadh. The indicator definition is a measurement or a flag used to guide, monitor, assess, and improve the quality of patient care, support services, and organization function, affecting patient outcome. And there was actually a quantitative measure in the rare-based numerous that stinted over time of compassion started and benchmark. So the benchmark was around that each hospital need around 24 months to get the SIBAHI through the using of essential safety requirement, but we tried to do it within 14 months, and we were succeed. Now we go to the deep of the study itself. The study is conducted in 2017. This was a quantitative study, first of its type in KSA. Data were collected through in-depth semi-structured interview with 45 multidisciplinary caregivers from actually different hospitals, working in different departments. We took from nursing, from pharmacy, laboratory, respiratory therapist, allied health, even we took from the phlebotomy, we took the physical therapist. So different departments and hospitals across the kingdom. The participants were selected using random sample method. Interview were transcribed and analyzed following a quantitative content analyzing approach. Written text was coded and themes were extracted from the data. Ethical consideration was approved from the Inaya Hospital, Inaya Medical Group hospital, which is my previous hospital when I was working in Saudi. The study was conducted with multidisciplinary free informed consent and was approved by the, as I mentioned, from the ethics committee. And the finding was that by analyzing the data for that 14 months, we found that distribution of the multidisciplinary over a different committees over 1 year and 2 months has improved the outcome of the achievement of ESR by 38%, which was actually a huge development or a huge increase in that, because in King Faisal before it was around 23%. That was our benchmark. So it took time from us, and actually this is actually approved by the Sibahi round in 2017, the Sibahi survivors. And I almost finished. I just want to arrange for the speak about the conclusion and remind you with the International Patient Safety Call, and I will show you what is the essential safety requirement that we discuss. The disruption for the multidisciplinary all over the hospital committees can improve significantly the percentage of essential safety requirement when being changed in yearly basis, with taking the consideration of active work for the committees and number of members. And also as a take-home message, that's actually a big problem for us, that we are dealing with patients every day. International Patient Safety Goal, which is to identify patient correctly using 2 identifiers, and even now hospitals, they start to use actually 2 identifiers and scan specifically for each patient, which is really using technology in the patient identification, and scan code with giving medication, double scan. Second one, improve the effective communication by using, of course, SBAR, by using emails, communication boards, MDTs, rounds, patient-physician round, patient committee meetings. All of this is the effective communication. And number 3 is to improve the safety of high alert medication, which is actually also a significant issue, that double check or independent check for using high alert medication, TBN, BBN, narcotics, muscle relaxants, insulin, Clexane, many type of high alert medication. And number 4 is to ensure correct site, correct procedure, and correct patient surgery, which is the time out for to be done before surgery, and also inside the surgery and after the surgery on counting. And reduce the risk of healthcare associated infection, which is, now in USA, they are spending millions of dollars to prevent this from happening, especially now we are in the COVID season, or we are in the COVID pandemic global problem. Reduce of risk healthcare associated infection by using hand washing, using PPE and sterile procedures, and the surgeries through the surgery. And number 6 is reduce of risk patient harm resulting from fall. That's also one of the 6 international patient safety. Now, also they're in worldwide, they start to invent like number 7 and 8 and 9 and 10, but it's not officially published. They adapted by the WHO. Now, the essential safety requirement that we work on was the credentialing, privileging, VTE for risk treatment and IT patient, timeout, anesthesia, qualified staff or recruitment, MDTs, facility or FMS, high alert medication, look-alike, sound-alike medication, and incident reporting medication error, blood bank prevent transmission, radiation safety, proper maintenance of gas system, effective fire alarm system and fire suspension system, fire exit and assembly points, and safe from fire and smoke. That's actually the 20 ESR that we work on our study, and it's really affecting the organization or building the organization of the hospital. So that's it for me. Thank you very much, guys. Any question? Hello? Can you hear me, doctor? Hello?
Dr. Saed Al Nobani, thank you so much. Sorry, I've literally just been unmuted by the organizer. I do apologize for the delay there.
It's fine.
That was an extremely informative presentation. Thank you a lot for that.
Thank you very much.
Can I ask the floor, are there any questions to be presented at this moment in time? Okay. It would not
If there's no questions, can you hear me, Mr. Tongi?
Yes, I can hear you, doctor.
Yes, yes, we can hear you.
Okay. Thank you very much for a very good presentation. I think this patient safety, it affects us all, and we need to improve on the quality of that. Thank you so much.
You're welcome. Thank you very much.
Can I just announce that our next speaker is not here, has not joined us yet. So can we prepare Ms.